Good morning, everyone. My name is Joan Batorf, and I'm a professor in the School of Nursing and director of the Institute for Healthy Living and Chronic Disease Prevention here at the University of British Columbia, Okanagan campus. Once again, thank you everyone for joining us this morning. I'm delighted to welcome you to our webinar. But before I begin, I want to acknowledge that UBC Okanagan is situated on the traditional, ancestral, and unceded territory of the Syilx Okanagan Nation. And I know that some of you might be joining us from many places, both near and far today, and I want to acknowledge the traditional owners and caretakers of those lands as well. So just a few housekeeping things before we begin. You will find a closed captioning button, perhaps on your screen. It's in a box and it can be moved around to your preferred location. And you can turn it off if you wish by selecting the live transcript button on the menu bar. We invite you to type in questions or comments into the chat box at any time during the session, and we'll look forward to discussing those with Dr. Capriccioni at the end. So today's event is brought to you by the Institute for Healthy Living and Chronic Disease Prevention at UBC Okanagan. And I'm really delighted to welcome Dr. Christine Capriccioni, who's a professor of physical activity and health at the University of Technology, Sydney in Australia, and used to be a faculty member here at UBCO some 4.5 years ago. So we're delighted to have her back today and to share some of her research around implementing exercise, counseling, and referral pathways in cancer care. So I'm going to turn it over to you, Christina. Thank you very much for coming and sharing your work with us today.
Thanks so much for that, Joan, and thanks for having me. It's lovely to be back, I guess virtually, but it's so good to kind of see everyone. Today I'm going to talk to you about some work that we've been recently doing in Australia and Sydney, and it kind of works around two of my passions, the idea of health services, but also in the cancer field, but also exercise and physical activity. Just starting off, oh, sorry, just a second here. Oh, it was working. I don't know. Here we go. So I'm sure many of you, because you have similar interests, are clear on the literature in that, exercise is actually both safe and beneficial for those going through the cancer trajectory. And we know there's many different physical and psychological and social emotional benefits based around that. And that can be anywhere from, pre-diagnosis, diagnosis, all the way to survivorship and living with cancer for many years. And what we do know is that despite these great benefits, people living with cancer are approximately anywhere 17 to 50% almost not engaging in the sufficient amount of exercise that can be quite beneficial to not just their day-to-day habitual work, but also some of the side effects that come along with their cancer treatment or when they're living with cancer beyond. Sorry. And we know that, numerous studies, particularly around breast, colorectal, prostate cancer, but we're seeing this develop across many different cancers, that actual patients are interested. They want to see advice about it. They are interested in being part of or being involved in some sort of exercise because they are well aware, similar to oncologists and the cancer care workforce, that it is good for them. But despite that, they're still not getting the information, or it's that really point A to point B referral process coming from oncologists, coming from oncology nurses, anywhere in the oncology workplace. And of course, there are many reasons and barriers about that. And I'm sure many of them are similar in Canada, but they are in Australia. And so many times when we look at the cancer clinician, and that could be oncologists, oncology nurses, what we do know is that they're not routinely discussing it for a number of reasons. Particularly, there might be this lack of confidence because it's not really their area or field that they have a lot of education or knowledge around. It could also be that limit of time based around the cancer consultation. And, you know, how do we make that, I guess, really a part of regular care? In Australia, a few years back, then Cancer Australia actually released a national framework. And not only were they kind of trying to encourage this idea of supportive living through, you know, making sure that we see this referral or communication from the cancer care workforce, but also how do we integrate exercise professionals or exercise specialists? And in Australia, we have a little bit of a different system in terms of our Medicare system, as well as our exercise consultants, and I'll talk a little bit about that. And I know that in Canada, I think they're still trying to develop something similar to our accredited exercise physiologists. We have, I think with CSEP, that's occurring now or has been trying. I remember when I was back in Canada. But we have accredited exercise physiologists, and every university that offers a sport and exercise program are most likely accredited by ESSA, which is our exercise specialist society in Australia. And through your degree, you also get accredited if you decide to go down that pathway. And so how do we better integrate these individuals? Because this is their bread and butter. This is what they understand, into more of a coordinated, integrated care facility or multidisciplinary, interdisciplinary team in terms of cancer care. So I'm going to talk to you about a project that we undertook. I guess it was 3 stages, and it really was trying to inform this later stage that I'll probably talk a little bit more about. We've just finished doing some preliminary analysis, but understanding, you know, is there a way that we could better get individuals from point A, so from the oncologist's consultation, to them actually engaging in exercise? Because in Australia, similar to Canada, we have great programs. So many programs that are, you know, group programs, individual programs, all based or focused around cancer care. But the problem in Australia, where the difficulty lies, is getting individuals from point A to point B and actually getting them to those programs. So that implementation process, which I mean, would be very interesting to a lot of implementation scientists. How do we do that better? And what's the most, I guess, simplest and supportive way for our patients? So our first kind of stage was this idea of gathering information, so very formative. And we looked at understanding a qualitative design, understanding, you know, why is this not happening? Why are not oncologists, why are not psychologists working in the cancer care team or oncology nurses not really referring, or what are the difficulties with that? And how can we better, from their perspective, integrate exercise professionals? So we undertook 7 focus groups. 5 of them were with our clinical care, our cancer care clinicians, which were medical, radial, surgical oncologists. We had oncology nurses, we had psychologists, social workers, anyone that was part of the integrated cancer care team. And then we also looked at 2 additional focus groups with exercise professionals, and these were accredited exercise physiologists, physiotherapists, exercise scientists. And and we found 2 main factors, the work that came out of here. And one was like, there's these factors that impact this idea of knowledge to action gap. And that really worked around the oncologists and their understanding of how exercise can be implemented, I guess, in a carefree way into standard care. And then we also had some great recommendations from both kind of the cancer care oncologists, but also the exercise professionals or exercise physiologists in how might we better do this, and what would a referral pathway, or what kind of changes do we need to make to the current referral pathway? And if we look at this a little bit more closely, this first idea, this lack of knowledge and education, and this really came from the cancer care clinicians. And, you know, they indicated that many times, and this is not new information, this is information that we see in Canada as well, is that they don't have that specific, or they lack that specific training or knowledge around exercise and how it could be implemented or integrated. They understand it's really good for you and really beneficial for their patients, but not exactly why or how it would differ between cancer types or tumor types, and how how best would they provide that evidence, or how best would they counsel their patients? The second kind of factor that impacted this knowledge gap was the funding structure. And I guess this is where it's a little bit different in Australia, and it actually could have changed in Canada, I'm not sure. But in part of our Medicare system, which is our universal Australian healthcare system, we have these 5 kind of complex patients, additional, I guess, consultations that you can have. And it originated with diabetes education. But these consultations are for complex patients where they could see, for a subsidized amount, a nutritionist or a psychologist or an exercise physiologist, an accredited one. And, you know, the patient, the doctors or the oncologists, as well as the exercise physiologists were indicating, like, you know, even if a patient uses all 5 of their Medicare primary care rebates on an exercise physiologist, this still isn't enough. Like, and then it ends. What happens afterwards? So how do we fix that funding structure? The other aspect they talked about was the current referral pathway. And to get these 5 actual, like, you know, Medicare rebates, what happens is that it has to be a referral from a GP. So, you know, the logistics around this is a nightmare for a patient. So they go to oncologist. The oncologist is not able to refer them on. From the oncologist, they have to go back to their GP, and they have to see their GP for 2 additional appointments to just get a referral to an accredited exercise physiologist. So, you know, this is madness. Like, how are we making these patients do this when they have so much more on their minds? And I guess the second theme was, what can we do, or what are some thoughts how we move forward? And number one, and again, this is something that's come out of the Canadian literature as well, or evidence, is that oncologist-initiated communication, and it could be as minor as just a mention of physical activity and healthy eating and lifestyle behaviors as part of that initial consultation, is crucial. And it needs to come from the oncologist, that idea of that credible individual that knows the medical history of that individual, and just that one brief little aspect. And then the next thing we talked about, or which were recommended, was more tailored resources, and not just for the patients, but for the oncologist. Can the oncologist get something really short, simple, and very informative? Can it be around different tumor sites, or some actual information and statistics? They wanted statistics around information to give to their cancer patients, so they could show, you know, if you do this amount of exercise, this is what could happen. And so we took that on board. And they also talked about, with the patients, as having tailored resources for the tumor site and at different stages of their cancer progression or their cancer journey, and how we could give that to patients, and when's the right time. And then thirdly was a development of this EP, which we are the accredited exercise physiologist network, but also making the EP making initial contact with the patient. And this was quite interesting, and was a big push between the oncologists or the cancer care clinicians, but also the EPs. And that was about, you know, first of all, having this network of EPs that had some specific cancer care knowledge and around exercise. So we actually have that in Australia. Many of our accredited exercise physiologists kind of focus in certain areas, and we have a whole group that focuses in cancer care. And some from very, like, early on, stage 1 to palliative care. So a whole array of different, I guess, knowledge, experience, expertise. But this idea too, could we switch this referral system where, you know, you have to go to the GP, you have to see the GP many times, and then you move on? Could we look at potentially having the oncologist refer, and then the EP actually making initial contact with, of course, permission from the patient? So these were kind of ways to think about as we move forward, and how we can, I guess, adjust or refine the current referral pathway. And so this really led to another, or part of stage 1 too, is like, we've got all this information from the oncologists, from the EPs, but we also wanted to hear back from the patients, or those that are going through the cancer journey or living with cancer. So the best way we felt was a large national survey, and we did do this, and we had quite a good response rate, considering. And in terms of completion rates, we had about 300, almost 300 patients, and across many different cancers, but the major diagnosed ones were breast, prostate, and most currently undergoing treatment. And we wanted, I guess, to make sure that we were on the right track with the information that we got from the focus groups. And of course, we definitely saw some really good overlap, and really helped, I guess, build our confidence that this is kind of where we needed to move to as next steps in terms of the referral process. Overwhelmingly, all patients, or the majority of them, agreed that exercise is beneficial at some point. Those that had had greater exercise beliefs or attitudes about it, or had previously been involved in exercise, definitely showed higher levels of exercise versus those that didn't. And they also indicated that connecting them with relevant services, resources, and being, I guess, utilizing the integrative cancer team in as many possible ways as we could to engage and help implement and, I guess, disseminate some sort of exercise resource or program was really important to the survivors, or them even just knowing about it. How can they do this? So from that information, we came together and we actually developed a half-day workshop. And this was specifically looking at how can we, I guess, edit or refine the referral process, but also oncologists were really interested in what they could do and simple ways that they could better educate their patients, or at least just provide that really brief counseling. And I guess we've actually moved it to the word communication, because we've realized that, and this is something that I'm sure many of you already know, that it's not necessarily oncologists, I guess, have the ability or want or have the time to provide counseling per se, but that brief communication coming from the oncologist makes like a very, very important starting point along the referral pathway. So together, it was great. It was difficult to get a number of oncologists and nurses in a room at the same time, but we managed to do so, and we got 4 great oncologists to be involved. We had a oncology nurse, we had some people from the research team, and then we had 2 exercise physiologists that were involved in this collaborative workshop. And during this time, we reviewed some of the main findings from the focus group and survey, and I guess joined or saw the alignments between the two, and that's where we kind of focused the attention. And a big thing that we wanted to do was design or develop these strategies and resources, but also finalize these plans of a referral pathway. And it may be just refining the current one, but that we could test for feasibility to eventually see, would this be a better way forward? So these are some of the key outcomes that we developed. As you could see, the one on my left, who might be the right, everyone else's, was specifically for the oncologists. And this is something they wanted to hang this up in their office, and they wanted to be able to be big letters that would catch their attention and and remind them, but very simple messages. And they really wanted that statistic aspect to kind of give to their patients, to kind of give them a wow factor, and just to see how important that was. So we actually, lending from, I believe actually diabetes, this came from diabetes, but this idea of the 3 A's to guide recommendations for physical activity for their patients. So we posted these. They were in nice colors, and they were in their office, and it kind of reminded them. And that was the biggest thing. They said, we just need something to remind us. And if we see it and it takes 30 seconds to a minute, we will do it. So that was the first thing. So we developed that for the oncologists, and we really worked with them to put this together. And then for the patients, similarly, and this really, a lot of information came from the EPs about how this could be put together. And this was really developed with the exercise physiologist, but really simple guidelines, simple information, and the idea that we needed to make sure that patients understood that this was more of a general aspect of what everyone could be doing, but these should be really, really tailored around the specific needs of the patient in terms of their the tumor site, the stage of cancer, but also, where they were in their cancer trajectory. And part of that should involve this exercise physiologist. And we provided some information about what an accredited exercise physiologist was on here, because many patients didn't even know that they had this option. So that's where that miscommunication really came within the health services system. So the other thing that we developed, and this is what we actually trialed with those resources, was this kind of refinement to the exercise referral pathway. And it just kind of gives you an indication. We developed this framework based on this information from the focus groups, the survey, and the workshop, and how it should look like as we move along, I guess, the pendulum or the progression throughout their cancer journey, and what aim each of this was. And an important aspect about this was, that, again, initial communication, and then it almost leaves the oncologist, but then comes on to the exercise physiologist, and the exercise physiologist is the one who will then make the contact with the patient and continue on from there and get them to transition not only into a starting point for exercise, but then how can they transition into more group or community-based programs in order to, be involved in a program that's feasible and that doesn't cost a lot of money, as well as is accessible, so close by that they can get to, and that would have to consider each individual and their own journey through the cancer trajectory. So with that, I guess this was our stage 3, and we've, well, not just finished. It was interrupted a little bit by COVID, as much research of everyone was. But so the idea was we just wanted to see that, I guess, that small point A to point B implementation point. So we actually didn't look at anything after the implementation of the referral process. And that would be our next step, is looking at a much larger trial. But it was really, our aim was to assess the feasibility and acceptability of what we considered a pragmatic exercise communication and referral pathway, with a sample of our cancer care clinicians and their cancer patients, and an EP that actually delivered this program. So it was really a single arm feasibility trial. We utilized semi-structured interviews at the end with the patients, with the oncologists or the oncology nurses, and with the EP to get some really in-depth information that we would hope then would provide further, or a starting point for then looking at behavior. All in all, we ended up doing 25 interviews were conducted involving 21 patients, 3 oncologists, and the exercise physiologist. And these oncologists and the exercise physiologists were the ones that were part of the implementation process. And just to give you a bit of an indication of what had happened, so we recruited the oncologists, we recruited the EP. And so the initial contact happened at the consultation with the oncologist. So what would happen is the patient would come in, the oncologist would provide, I guess, the standard of care that they would normally provide information around the treatment, next steps, depending on where the patient was in their cancer journey. And then at that point, they would use our 3 A's to assess assess, aware, and advise. And then they would indicate, we're actually undertaking some research right now, and about you being or provided with some consultation with an accredited exercise physiologist. Would you be interested? And at that point, they said yes or no, they consented. The oncologist walked them outside to our research assistant. Of course, that's not what the normal strategy would be, but we had to provide them with more information, consented again formally. And then they were told that an exercise physiologist would contact them within the next week to 2 weeks of this initial appointment. And so that's exactly what happened. The exercise physiologist, and it was a telecommunication, partly because we wanted to see how that would work initially, but also we were restricted in Australia at that time with our COVID restrictions. So the EP rang the patient and had about a 15 to 20 minute consultation with them. As part of that, they took physical activity history. They went through some really specific physical activities for that individual based on the history and based on the current level or current, I guess, part of their cancer, where they were in their cancer journey. And then they also, EP was excellent in being able to find local resources, and that would be online resources, but also local community programs that were offering cancer-specific exercise, and exactly kind of what the program was made up of in terms of, so they would understand, if a patient that was a lung cancer patient and was very restricted, then they had some at-home exercise, I guess, resources for them, versus someone that has been 5 years post-treatment, doing really well, but needs to be doing exercise and needs that social support. They would find some community-based programs that were local, accessible, and an option between those where they could use that 5 Medicare rebates or those that were free. So we did find this mix that many of them, there was still a fee to that. And then the EP ended the conversation, and then that was pretty much where we wanted to stop this study at this is what our focus was. A week later, we had our research assistant contact the patients and interview them based on just that kind of process. So I just want to share with some preliminary feedback as to, or results that we got up to this point. So it really, we found about 3 themes that were really, that came out of the data. And this provides just an idea of some of the feedback or some of the information that the patients or the oncologist or the EP gave to us. And I guess that first one was that navigating the role of the cancer clinicians. And what we heard over and over again from the patients was that initial contact with their oncologist professional and just, mentioning it or just even bringing it up as part of their consultation was really important to them, because it made them think, oh, if the oncologist is bringing this up now, then it must be something that I should do and quite beneficial. And that's exactly what the research tells us. So that really reinforced what we've been talking about. And also, the idea that it wasn't the cancer care clinicians, I guess, role to provide that in-depth counseling, but if they could just mention it and refer them on to an EP, then we could see that link really, or that gap in that link decreasing. Another theme was making sure that we had this really patient-oriented care and within this standardized pathway. So the EP talked about how important it was to get medical history and diagnosis and where they were in their cancer journey in order to provide the best information, to provide the best resources, but also so the EP could be well aware of what's going on with this patient. And there may be a local EP that has more experience with this particular cancer that this EP could then refer them on to. Excuse me. And another aspect was, definitely there is a support, and some of the patients indicated that, but they were unclear of, they could do this exercise stuff and they could have this exercise physiologist. And when that exercise physiologist contacted them and I guess tailored the conversation around that individual, they really felt, oh, this could be beneficial, and how they can move on and get that help. And we also talked about, like, the third theme, I guess, that came out was these taking these steps of actions forward. And again, they were indicating that how important it was from the oncologist to get that perspective, but also that idea that they have to go to the GP in order to then get referred, and they had to see the GP more than once in order just to, I guess, access these Medicare rebates. And the EP indicated that was a huge barrier for them too. And how can we overcome this? And this is obviously a policy change that we're looking at now with Cancer Australia, but is it necessary? Why can't the oncologist actually refer them on? And that's become a major barrier, not only for the patients, but also for the exercise physiologists, because they're just sitting there waiting where they could be actually be quite active and getting the individuals involved. So I'm just making sure. And as I mentioned, you know, this project itself wasn't about behavior change in the long. Well, we didn't measure behavior change, but with the idea that the next steps would be, you know, what happened afterwards? Did those patients actually use those resources? Did those patients go to those community programs that the EP got involved? Did the patients use their 5 Medicare rebates? Some of them never even know that they have them or that they could use them for something like this. So what a lot of patients did come back with, and I think this really kind of sums it up nicely, is that it really kind of changed their mindset. It gave them information that they didn't know they actually was out there. It provided them with the information about how this EP or exercise physiologist could really be beneficial for them, and that they actually had access to these individuals, again, for a short period of time. But it also made them think, you know, I need to start thinking about how I can integrate exercise and healthy living as part of my treatment to support, not necessarily my treatment that I'm going through, but side effects that are happening still 5 years later, and that they could be doing this stuff and it could be so beneficial, but how do they actually get to that point B, or how do they get to that implementation stage where they can actually access these great programs? So I guess we're now looking at, you know, where to from here. So at this point, we're still reviewing some of the data, but some really important, I guess, future findings, but considerations of how things need to change, especially for practice, is kind of where we are now. And I guess number one take home point is that first point of contact with the oncologist or with the oncologist team, the nurse, becomes that teachable moment. And as I want to reiterate, it's not the fact about providing in-depth conversations or consultations with the patient, but it's that communication. That oncologist just mentioning, okay, so here's your medication, you know, medication adherence is important. This part, you know, understanding your stress levels is important, getting sleep is important, and making sure that we're exercising and moving all the time is really important. So that including that into that standard care is, you know, absolutely necessary. One thing that I forgot to mention as part of that is, you know, the oncologists are still thinking, oh, it's got to be part of standard care. It's so good. But their mindset is still that, oh, I don't have the time to make it part of standard care. So I think that's where we need to shift to, is that if they have to start getting to the mindset that this needs to be part of that initial consultation with the patient. That is going to be the first step of developing that teachable moment. And in order for us to get to that point, and in order for the oncologist to feel like they could do that, we have to make sure that they do feel supported. Some of the other resources they talked about that would be really important is to have additional training as an oncologist. And when I left here almost 5 years ago, Canada was actually really ahead of this, and they're doing a great job. And I had a student working in this area, and what she had talked to about was that the board exams for the medical for doctors in Canada had actually put out a statement indicating to many of the medical schools that eventually the board exams would include a large portion of lifestyle behavior type questions. And at that point, you know, they were kind of giving the heads up, if we're going to be testing this, you got to make sure that these medical schools are teaching it. And so I think in Canada, we see the shift now that they're including that more within curriculum, even if it's just a little bit. And so I think we need to see that in Australia as well, or how we can support junior docs or any docs that are coming through, becoming specializing oncologists, and where they can at least have enough information or, I guess, confidence to provide that brief communication. Sorry. Another thing was, we really need to better integrate the accredited exercise physiologist. So another lesson for Canadians as they move to doing the same thing that we're just not doing really well is we have this great professional group. Exercise physiologists, they're accredited. We have some that specialize in oncology care and exercise, but we're not utilizing them. And yes, part of that is the medical care system, because we obviously have to pay extra for that. And we do have a 2-tier system in Australia where we do have private health insurance. So that is often part of private health insurance, but not everyone in Australia has access to private health insurance. So how are they not part of this multidisciplinary cancer care team? How are they not part, like we would have like a psychologist or a social worker? So getting them involved at the start is what the oncologists are telling us, what the accredited physiologists are telling us, and what the patients are telling us. So, you know, everyone's telling us this, why aren't we doing this? So again, probably a major policy change there. Training experience related to cancer-specific treatment around exercise is going to be really important, especially for exercise physiologists. We do have some of them, but we need more of those. And of course, what the patients did tell us and what really worked well was this exercise physiologist initiated communication. So first change, the oncologist gets to refer them on, or at least contact an EP to say, this patient definitely wants to hear from you. Then the EP within a week contacts the patient rather than the other way around. And we saw the adherence to this, or just the discussion around this, so much more, I guess, positive than previously how the referral process is going. Our Medicare funding structure, you know, I guess that really depends on what government is in play at the time, similar to Canada. But we really need to know that these 5-session care plans are just not adequate. Cancer, as many of us are aware, is a complex disease, and it can be very different depending on the patient. And we need to be able to support them at any aspect of that journey. And I guess changing that referral where they have to go, the logistical part of going to a GP in order to getting this referral to even to those 5 sessions is just not feasible. It's not good for the patient. It's not good for the oncologist, because then it, like the lack in time afterwards too, the oncologist doesn't hear from the GP, so they don't know what's happening. It just extends this lack of communication, or it just really dampers on the integrated multidisciplinary cancer team. So how can we better do that? Well, why shouldn't the oncologist or the nurse be able to refer their patient onto a accredited exercise physiologist? So some things that we're thinking about, things that we're now considering to move forward and testing in a larger trial. And we're still working through this data because, as you can imagine, there's a lot coming out of it. And but for now, that's about it. So thank you, everyone, for listening, and happy to answer any questions or have a chat to anyone.
Great. Thank you very much, Christina. I encourage people to add a few questions or comments that you might have about this topic in the chat. And I think it's kind of interesting to think about this in terms of what happens in Canada. And I know that there are many people in Canada that are concerned about this issue in terms of supporting cancer patients in engaging in physical activity. And I think sometimes I think patients, but also healthcare providers, are not sure when we're talking about physical activity. Are we talking about, you know, going to the gym and running on a treadmill, and that you have to go to a gym and that kind of thing? And I know you don't, but I think when people hear exercise, they think they're going to have to do something really vigorous.
Yeah.
And they think, oh, no, I'm not going to do that. That's not for me.
That's really interesting, Joan, because we actually, believe me or not, we toyed up with the idea of using the words, and this again is really important, the communication, right? The terminology you use with the idea of physical activity versus exercise. And what we did find, even talking to patients, many were still like, well, many people don't understand what physical activity is, and realizing, right? But because exercise has been such an important word in the oncology field, but also because our CASA, like our clinical oncology statement, it uses the word exercise. So we're trying to be consistent, and because our exercise physiologists are exercise physiologists, right? So in saying that, though, we are really trying to develop that communication where If it means going outside, walking to the end of the street and back, and that's all you can do for the day, brilliant. It's better than doing nothing, right? And so part of those resources too really look at that step progression and talking about do something, anything that you can do, and see as you get stronger if you could progress that on to what we, I guess, would consider exercise.
Yeah, that's great. So there are some questions, so I'm going to go to them. Carrie asks, would you prefer exercise physiologists to kinesiologists? And you might have to explain the difference here.
Yeah. So interestingly, I know both kind of systems. We actually don't have kinesiologists in Australia. We do. In terms, it is a weekend online certificate that you can get from some random, not accredited institution. So we actually, exercise physiologist is our go-to in terms of that. But in Canada, it's very different, right? And in Canada, absolutely, we should be using kinesiologists. And if we can get them trained around, providing cancer-specific treatments, because accredited kinesiologists are very different in Canada. And I would say here, absolutely use them. Use whatever resource you have available or service that we can get patients the easiest, most feasible, most cost-efficient way. And if that is the use of a kinesiologist versus an exercise physiologist or an accredited kinesiologist, then that's the way to go. But unfortunately, we just don't have that in Australia. It doesn't work that way.
Okay, great. Another one from Rebecca. Very insightful talk. Christina, can you explain why there's a 1 or 2 week lag between referral to EP and the EP making the phone call to the patient?
Yeah, honestly, that was just a resource issue for us. We would hope if the EP could contact, because I mean, these the oncologists saw a lot of patients and we were lucky that many of them were very interested, but the EP just couldn't. We had one EP that was involved. So when I say they didn't wait a week, they started contacting them a few days afterwards, but sometimes it took up to a week to get to some patients. Other times when the patient met with the research assistant, they actually scheduled, almost said, they can call us on this time. It just happened to be. So that's a real variation or range. Our longest time that we had to wait, and that was because we just couldn't contact the patient, was up to 2 weeks. But then when we contacted them, they were a little like, oh, I don't remember. But then when we talked a bit more, they were like, oh, yes. Oh, my God, yes. And they were very receptive to the chatting. So I would say on average, it was anywhere between 3 days to a week that we got most of our patients to chat to them with the EP.
Mm-hmm. Great, great. So, when I think about our situation and in BC and many places in Canada, we might not have an exercise physiologist or a kinesiologist down the street that we could go to. And so access becomes a bigger issue for us. And so I was interested that your EPs were providing kind of virtual exercise support. So I'm wondering if you could just talk about that a bit more and sort of the long-term feasibility of that kind of approach.
Yes, sure.
That would certainly enhance access for our cancer population to this kind of service.
Yeah. So I do want to, I guess, stress that initial contact with the EP wasn't necessarily, like, they didn't prescribe them an exercise program at that point. It was to provide them information specifically around, I guess, their cancer and their stage. But it also provided them, because this is the exact reason why we were like, how do we get them, especially those that are in remote areas of Australia or in New South Wales, similar to like Northern BC or something like that. How do we get them to access anything? So with the patients, the actual EP did a lot of research ahead of time and found anything that, I guess, resembled something that they could do in their local area. Some were more difficult than others, or the closest. And if they couldn't find any local resources, and when I talk about resources or access to services, it could be like a community center that they may have had an exercise specialist, so it wasn't or someone that was doing something that knew something about exercise at a local community center that also had some knowledge or could take. They're more cautious than not, so that could take patients with some sort of chronic disease or managing through chronic disease like cancer. The other option was, what she also did was, for those that were really remote, that she couldn't find any, because we had some individuals that were on properties that were 300-400 kilometers away to any services. So online services, she found for them resources, because that's the last thing a cancer patient or their family wants to be doing, looking online. What are the best cancer resources to do online physical activity with or exercise? So the EP actually found those for the individual and just, provided those right away, so they could just click on it and it was free and they could do it. The other, I guess, a positive that we had to consider in that aspect is we're really lucky in Australia. They have very good internet in a lot of places, and the government has that was the major government went through major changes in the last 10 years. But one of the things that many of them did was making sure that remote areas had access, and very good access. So the internet out there is very strong and it's good. So for those really, really remote areas, the only access they had that was feasible was online. But just talking to those patients too, just the fact that it took away 3 hours of searching for things that were relevant on the internet for them. And they were provided with maybe a online group exercise program that was specific to those that are recovering from breast cancer surgery. So that EP was fantastic. But we have fantastic EPs that we're just not accessing. So right. We were able to, she did this, and we were able to provide funds for her to do this over, the 30 days or the month or the time period. But that's another thing, that was paid out of a grant. So we're still going to need an EP to spend that time just doing that information. And where does that money come from, right? So these are things that, how do we do this to provide the most access for those that are remote, for those that are not remote but can't leave their house? And all of those options are starting to come together now.
So I'm assuming that if people didn't want to leave their house for whatever reason, and on a really cold day like we're having today, people might not want to leave their house, that there are exercises that they could do at home with what they have at home. Yeah. I mean, it doesn't require going to a gym, really.
No. And I guess that was an important part of that brief conversation with the EP, was the EP really provided them with information about, to get you have to do so much more less than you think in order to gain even a little bit more benefit. And if that benefit is, I want to sleep better, but I'm really struggling with my side effects of my chemo right now. Or I want to be able to, so the EP would look at that aspect and say, there's this great program here. It's chair yoga or chair Pilates, or it's, you could do it at home. You don't need any equipment, but if you have some water bottles or you have some soup cans, and that's where the EP was really able to tailor. And I think that's where the patients really felt this was so beneficial. So, that brief 15-minute conversation helped so many of those patients just understand and be aware. Yeah. And that for us was a big win.
Yeah. No, that's great. I'm assuming that there is some of those resources available online in Canada as well. I'm pretty sure we have some experts working in this area. So I'm sure that's true.
Yeah. The work, there's so many. The Ontario Cancer Council has some great stuff. They also have some great stuff around additional online modules to help training. So that was really important. Training exercise specialists, but also health professionals that might be interested in more cancer specific. There's some great patient stuff. And we looked at a lot of that stuff when we were developing these kind of trial prototypes. And one thing, the doctors loved the sheet, but they were like, we still need a little bit less words.
Yeah.
Oh, I'm like, so we're trying to figure out the best way to refine
Yeah.
that. And the cancer patients got this very easy take home thing that just got them started and just, if anything, built awareness. And they thought, okay, just seeing this by doing a little bit, I can really help be beneficial to me. And I think that was the starting point. So now we have to see if that actually was a starting point and if we do see some behavior change after, and those are our next steps.
Yeah. Yeah. No, that's great. I know that, from my own work in the area of tobacco and smoking cessation, it can be really difficult to encourage cancer care professionals to integrate some advice, whether it's around exercise or tobacco use, into their practice. And many of the same reasons for not doing it are the same for tobacco. And one of the things that had over the years, we've tried to, in Canada, begin to introduce smoking cessation counseling into cancer care. And one of the ways that we've tried to convince cancer agencies and professionals about the value of it is that it actually optimizes cancer care. And there's lots of evidence for smoking cessation. And I suspect there's similar evidence around exercise that it actually optimizes care. So then if I'm a cancer patient and I know that exercise will optimize my outcomes, it's like, how come I'm not hearing about this? I think it's, and also it ends up saving our cancer care system all kinds of money if it optimizes outcomes for patients. And in some cases, it's as good or better than the actual cancer treatment that they're getting.
I know, and it's exactly the same. And of course, for the 90 or the 9,000 oncologists that think it's great and are trying really hard to do it, we still have 1,000 that don't believe in it, right? Which is okay. And they're still, no, you're going to overdo it, hurt yourself, and it's just like, oh, but I guess that's the point where so the oncologists that do think it's great and beneficial and they know it works and they do try to make it part of standard care, they're not really supported, even though the literature says this, even though the government is saying do this, even though their hospitals or their private clinics are saying, you need to do this, they're not actually supporting their ability to do that. Right. And so, the oncologists, it can become quite difficult. And I guess they're thinking to themselves, like, this patient has just received a major diagnosis. They're trying to process that. They're trying to process the idea of, okay, now they've got to start treatment. They've got to their whole life is going to change. And, if we throw exercise in there, it's too much for them to think about. And I was like, but that's the whole point you're missing, right? Like, if we did tell them about the exercise and that it could help with a lot of the stress that they've just encountered, and the fact that their life is going to change majorly. And maybe when they're thinking about that, if they went with their partner or with their family for a walk and talked about it, right? Just that simple walk while they're doing that. So there are little things that they could be doing. And so how do we best support them so they make it part of standard care? And like you said, Joan, it's the same thing that you're having with the tobacco. That's it, right? So I guess we just keep working away and hope for the best.
Yes, exactly. So I don't know, it's almost like a system change is needed so that it becomes part of the record. Like there needs to be, and part of it might be, there needs to be a box that you have to tick off or comment on that some advice or communication around exercise and physical activity was included in those conversations, whether it be by the oncologist or the nurse or whoever is working with that patient, but somehow that it gets recorded. It's almost like, do you smoke? And if you do, then there's a box like, did you give the patient advice, or was
or you mentioned it? Did you even talk to them about it? And you're right, it has to be a system change. And I mean, last year I had my own mother dealing with a cancer diagnosis and stuff, and trying to figure out, and I sat in that initial meeting, and it was quite the irony, I can't believe it, because I'm doing this work and not one word, not one mention of any of exercise, of healthy eating, but here's a binder for you of this much information. And there's some further information you should look at, but still no mention about, and when you go back, that further information is about, you know, you shouldn't be smoking, you shouldn't be consuming alcohol, you should be exercising. And I was like, no patient is going to sit here and go through all of this. And, you know, like, I was amazed, and I'm just like, oh, but it has to happen within the actual system, right? Like, we have to change how we, and it's not necessarily the oncologist's fault. They've never been taught that. They don't have that knowledge, right? So anywhere that we can get the information, I guess, is going to be really important.
Yeah. And the other thing you didn't mention, but also is equally important, is, you know, as we all know, cancer is most prevalent in older adults, but older adults commonly are also facing and dealing with other comorbidities like diabetes and heart disease and other things, where, of course, exercise, smoking cessation, healthy diets are all part of what you need to do for those things as well.
100%.
So it becomes even more important.
Yeah, no, again, another way that almost we could sell it, you would think, but yeah. So, I mean, we're always open for new ideas from anyone around that has experience, but you know, just struggling to make these changes has been difficult. And even the oncologists, they want to make these changes, but like I said, if the environment they work in is not supporting those changes, which is really odd, because like in Australia, I wouldn't say that they were ahead of Canada, but we actually have developed our own like government funded cancer recommendations, and this came out before ACSM developed theirs just last year in 2019, right? And so the COSA statement, as well as the cancer and exercise guidelines, have been in Australia. I think 2017 they were developed, and that was a statement coming from the Clinical Oncology Society of Australia and supported by the government. And we're still not moving any forward on that. So, yeah.
All steps. I see Carrie has put in a comment. We have physiotherapy clinics in BC who have kinesiologists and even pilates instructors who provide funded exercise under extended health benefits. So thanks, Carrie, for letting people know about that. So
yeah,
have some support for cancer patients.
And I think, if I recall, I think some work that was done at Nicole's lab in Calgary, they were doing some yoga stuff similar to the Pilates. That was similar. And I was like, this is brilliant. And it's not that we don't have the programs. Like Australia has the programs. We have amazing programs, but we got to get patients to those programs. Right. And that's the issue, right? Getting them from point A to point B. And that's where the problem is. Yeah,
that's great. Well, I'm glad you're working on it, Christina. And I know that there are other people who are interested in this challenge in Canada as well. Mm-hmm. So I see we've run out of time. So I want to thank you so much for sharing this work with us, and wish you luck in the next stage. You'll have to come back and tell us about the next phase. Yeah, it would be great. So I do want to also thank everyone for joining us today, and I look forward to have you come again. So I'm going to sign off, and so thanks again, everybody. We'll see you next time.
Thanks, everyone. Thanks again for having me, Joan.
All right. Bye-bye.